Good morning. Today we will having a case discussion and a operative procedure on submandibular salivary gland. Dr. Basu is busy with some other assignment, so he cannot join today. I will continue. The presenter will be Dr. Abhishek Narayan. He is MS PGT at Calcutta National Medical College. Now he is on district residency program at MR Bangalore Hospital. So Abhishek, you could share your screen and present, and then we'll continue.
Good morning, sir.
Go back.
Good morning, sir. So this is a case of submandibular swelling. Steps of submandibular. So patient XYZ, 43-year-old male, who's a farmer by occupation of Hindu religion. Came with chief complaints of swelling in the upper part of the right neck for the last 1 year, and the pain over the swelling for the last 1 year. Patient was apparently normal 1 year back, after which he noticed a swelling below the right jaw in the upper part of the right neck. It has gradually increased in size for the last 1 year. Swelling exaggerates during meals and subsides after the meals. Initially, the swelling used to disappear in between meals, but for the last 2 months, it has become persistent and it gets aggravated. The swelling size of the swelling gets aggravated on taking meals. It is associated with the pain for the last 1 year, which is intermittent, dull, aching type, exaggerates on taking meals and subsides after it. So actually, the patient initially told that the pain and the swelling came at the same time, but on repeated, I asked him 2 or 3 times, and he told initially he had pain, followed by which the swelling had come. There was no radiation of pain, and the pain subsides on taking medication. The swelling is not associated with any pus discharge from the floor of the mouth. There is no history of any other swelling in the body. There is no history of pain during swallowing or difficulty in swallowing, drooling of saliva, redness over the swelling, toothache, and sensitivity to cold and hot substances. There is no history of weight loss, no history of radiation to head and neck in the past. There is no history of joint pain also, and no history of tuberculosis contact. Past history, patient is non-diabetic, non-hypertensive. There's no history of COPD or asthma, and the patient has no history of undergoing any previous surgical procedures. Patient consumes a mixed diet, normal bowel and bladder habits, normal sleep pattern, and is a smoker for the last 10 years. No significant history of allergy to any specific substance or drugs. No significant family history.
Okay.
History.
Okay. From the history, you have covered the salient points in history, but patient having a submandibular gland swelling, you said there is no other swelling. Okay. Why did you ask about the other swelling in the neck or other regions?
Sir, can be a lymph, like a swelling associated with lymph nodes can be there. Think of then.
Apart from lymph nodes, can there be swelling of multiple salivary glands?
Yes, multiple, like if you take Sjogren syndrome, bilateral swelling or multiple.
So there are some autoimmune diseases where different salivary glands are affected. And then what symptom patient may have? You have not mentioned that part.
Sir,
patient may have dry mouth, or patient may have dry eye. So you should ask that patient no history of dryness in the mouth, or he doesn't feel that the eye is becoming dry. So that exclude that patient does not have failure of secretion of the this. And from the history, if you try to find out the possible cause of this swelling, what do you think?
Sir, most probably it is due to blockage of the submandibular duct, that is the Wharton's duct, because that is why the pain or the swelling size increases while eating. So whenever there is increased salivation, and that is the time that swelling of the swelling.
Yes, this is a classic history. You see, the history is like this: that patient has got a swelling and pain at the same time, and that get aggravated on taking meals. That indicate that there is some type of obstruction. This may not be stool contact. That may be a stenosis on the duct orifice also. So, and then the swelling initially was disappearing, but subsequently, how do you explain that the swelling is not getting disappeared after he takes the meal? What might have happened? Initially, you said the swelling comes up during eating,
Yes.
pain, and then after some time the swelling disappears, pain disappears. Now the swelling is now became persistent.
So due to long-standing and chronic sialoadenitis,
So that is superadded inflammation.
inflammation.
Because of sialoadenitis, the swelling is now getting regressed. Okay, so you mentioned that part also, that there is no, and then you see again, once you take family history, no history of similar illness. So if it is a stone, that the stone doesn't run in families. But if you think of some autoimmune disease, then autoimmune disease may have some familial background. Okay, otherwise, it's so use this
Terms of
line
as and when
sparingly.
necessary.
No, it's a similar illness. If you mention something like this, that indicate that patient might be having some disease which has got a genetic background. Okay,
Yes, sir.
fine. Then examination.
So patient is alert, conscious, cooperative, oriented to time, place, and person. Average build. Nutrition is within normal limits of BMI 23. Karnofsky score is 90. 134/78 is the blood pressure. Pulse is 78 per minute regular. 99° Fahrenheit temperature and 16 degrees per minute respiratory rate. So a local examination. On
You should
examination.
mention here examination of the neck. Try to understand.
Okay.
Once you say general survey and then studying local examination, this
Local
area varies.
examination.
Here you have a swelling in the neck of the right side, so you are examining the whole neck, not the only the gland itself. So it's a local examination dash examination of the neck. Okay, carry on.
So on inspection, the swelling is observed to be in the right submandibular triangle, so globular in shape, around 4 into 3 centimeters. Smooth surface and the margins are regular. Skin above the swelling shows no pigmentation, no ulceration. There is no color change or scar mark. On palpation, the swelling is firm in consistency. Temperature is not raised, slightly tender. Skin above the swelling is free, that it is not fixed. The swelling is mobile and appears to be free from the underlying structures. On examination of the oral cavity, enlarged submandibular gland is noted on bidigital palpation, but no stone is palpable on bidigital examination of the gland. The examination of the other salivary gland is within normal limits, and no other swelling is palpable in the head and neck region. Examination of cervical group of lymph nodes is within normal limits bilaterally. Oral cavity examination, mouth opening, teeth clenching is normal. Systemic examination is normal. So there's a 43-year-old man present with swelling in the right submandibular region, 4 into 3 centimeter in size, associated with pain, which is exaggerated during meals. The swelling used to disappear after meals, but has been persistent for the last 3 months, with no features which are suggestive of malignancy. On examination, we can see a firm swelling with regular margins, globular in shape, 4 into 3 centimeter, which is free from the underlying structures in the overlying skin. Stone is palpable in the right submandibular duct at the floor of the mouth. So probably this is a right Sialoadenitis, and the cause of this probably might be the salivary calculate present in the duct.
Okay, means chronic sialoadenitis with
Right
possibility right submandibular duct calculi.
Because the stone is palpable.
You said stone is not palpable.
No, stone is palpable.
You said palpable.
Yes, sir.
Okay.
Yes.
The examination.
Sir. That also.
Go back.
Oh, I think sir, right.
Huh?
Mistake again.
Thank you.
No, sir. No,
You see, it's not always that you can palpate the stone. It's a small stone, the matter of inflammation, you may not be able to palpate the stone. So these two should be tallying. Here you say no stone, and then you are saying the stone is palpable. Okay. So you see, if you once you palpate the stone, the diagnosis becomes straightforward. Okay. So if this is the diagnosis, and suppose you are not getting the stone palpable, and patient has got this swelling in the neck. Why do you say this is submandibular gland being enlarged? Why this swelling you are palpating, you are saying there is submandibular gland? You say it is submandibular gland. Clinically, what is the points in favor that is a submandibular gland?
It is bidigitally palpable.
First talk about
First the
region.
region.
Look at in the submandibular
Submandibular
triangle. The swelling is there in submandibular triangle. The swelling gets aggravated. The pain gets aggravated during pains. And these are classic features of a submandibular gland being enlarged. So location of the gland, the submandibular triangle, the swelling gets aggravated, pain gets aggravated on taking meals, and then it becomes visible to some extent. And then on examination, the swelling is bidigitally palpable. Why a submandibular gland is bidigitally palpable is the explanation.
Sir, because it has the superficial lobe and the deep lobe.
Okay.
Evaluating from the
Where is the deep lobe located?
Sir, the mylohyoid muscle is the separation. That is, the part superior to the mylohyoid is the superficial lobe, and the deep to the mylohyoid is the deep lobe.
It's between the myloid and what muscle? Deeper?
Hyoglossus.
Hyoglossus. So hyoglossus is from the floor of the mouth. So it's really palpable because this gland is indented by mylohyoid muscle. And part of the deep part is in the floor of the mouth. That's why if you keep the finger in the floor of the mouth and outside finger in the neck, so with outside finger if in the superficial lobe and the deep lobe. So this is bilateral. And submunal node is located where? Submunal node is located where?
No, not really 100%.
You see, if you talk of mylohyoid, this area is what? Submunal triangle. And submunal node is lateral to that. So this node may be deep to deep fascia, but it is not extended to the floor of the mouth. The enlarged submunal node will not project in the unless it's very big. You see, it's a large node which can project in the floor of the mouth. In that case, it is difficult to differentiate as a node or a gland. So usually submunal node is in the submunal triangle and not in bulging in the floor of the mouth. So that's why it's not a bidigital palpation. Don't say bimanual, it's a bidigital. Okay. So this is the working diagnosis. Okay. What should be your approach for managing this patient?
Sir, we can confirm a diagnosis with an ultrasound examination. Previously, it was told that X-ray was given, X-ray of the, but since only 80% of the stones are radiopaque, better to do an ultrasound examination because we might know the contour.
No, don't defy. You see, still people are doing a good X-ray can show the stone. 80% stones are radiopaque. Understand? So you can say I'll do the ultrasound is a investigation which is done technically. So ultrasound you can say in almost all patients. Any swelling you can do an ultrasound. So I'll do an ultrasound and assess the extent of the swelling enlargement. And then if you trace this, you can find a stone with acoustic shadow. Else, the stone can be seen by an X-ray. What X-ray you advise for this patient?
Sir,
what is the X-ray called as? If you want to see the floor of the mouth, you keep the plate and then take an exposure. What is that called as?
Orthocontour.
No.
No, sir, X-ray of the.
This is called as intraoral occlusal view. You place the plate in the floor of the mouth and take the X-ray from. It is described as intraoral occlusal view. That means on keeping the plate inside the mouth, you close the mouth and take the X-ray. So you say intraoral occlusal view. Okay, you can see the stone. 80% stones are radiopaque. Okay, so you say it's a case of stone disease in the submandibular duct. Why stones are more common in submandibular gland?
Stones are common because there is the secretion of the submandibular gland is more viscous and it is also anti-gravity dependent. That is, stasis is more in the submandibular duct.
Yeah.
So that is why the stones are more, and also contains more calcium carbonate compared to the other like other salivary glands.
Other glands have calcium. All salivary stones, 80 to 90% radiopaque. It will contain calcium. But here the gland secretion is more viscid, more mucus. And because of this duct going higher up from the gland, it may cause stasis and there may be precipitation of this calculation. And then precipitation occurs around what?
What means which anatomical structure?
No. As you go to the genesis of the stone, what happens? There is some denuded epithelium. Because of the inflammation, there is some denuded epithelium. And around this debris or epithelium, this become the nidus. And around this, because of stasis, the calcium start depositing. So that is the genesis of stone. Okay, what are the incidence of stone in parotid gland?
Sir, relatively very less compared to the submandibular.
Around
15 to 20%.
Around 10%. Why the parotid ductal calculi are less common? Why parotid ductal calculi are less common?
Sir, because the drainage of the duct is gravity dependent. It's not.
First is secretion. The secretion is more serous. In parotid gland secretion is more serous. That is more water. And the duct directly drains
Drains.
from the thyroid gland to the
second molar, second
yes.
molar.
So there is no stretching. Okay. What are the other salivary glands apart from parotid and the submandibular?
Sublingual glands are present, and then the minor.
Where are they
salivary
located?
glands. The sublingual glands are present just in the side of the frenulum of the tongues.
Frenulum tongue is
Yes, sir. Just
point.
lateral to it, just
Yes.
where the submandibular
sublingual glands lies in the floor of the mouth, lateral to the
frenulum.
course of the
Submandibular
submandibular duct. If a trace submandibular duct, the lateral bulge on either side is the sublingual, and minor salivary glands are present in the oral cavity, in the cheek, in the palate. Okay, so the other location of the minor salivary glands. Okay, you have demonstrated the stone in the duct, and you said the swelling is also palpable. What should be the optimal treatment?
Sir, it depends upon the size of the stone and where the stone is. If the size of
If
the
the stone is the duct, he said you can palpate the stone in the floor of the mouth.
Yes, sir.
Okay, so what are the treatment you like to offer for this patient?
Sir, there can either be, sir, if the size of the stone is less than 4 mm, then we can remove the stone by using a Sialoadenoscopy or a Dormia basket. And if the size of the stone,
Put it on your basket.
the Sialoadenoscopy. As a pneumatic lithotripsy was also given in the book, but I was not sure if I can mention it or not. Sialoadenoscopy only.
Then what else?
Then if the stone is sir, proximal to the crossing of the lingual nerve that is close to the submandibular
Then
gland.
if for palpating the floor of the mouth, it is quite far away from the lingual nerve. Lingual nerve comes in the hypoglossal muscle, in the deep part, of the gland. Lingual nerve is close relation to the duct as it crosses around. But once the duct goes to the floor of the mouth, their lingual nerve is not there. You can safely make an incision on the duct on the floor of the mouth. Lingual nerve is not there.
So what we do is, if we are going to open the duct, what we'll do is a proximal ligature we will take, and then so that while opening the stone doesn't slip and go up.
And
so
once you remove the stone, what should you do?
Once we remove the stone, sir, we can close the duct with 5-0 proline.
Close the duct. How can
or we can like make it drainage into the floor of the mouth.
How? If you make an incision, so the duct is open. Then you cannot close the duct. It's a very fine ductal structure.
We can make it drain into the floor of the mouth.
Yes, you make suture between the mucosa and the duct wall on either side, so the duct remains open. Duct will remain open in the floor of the mouth. What are the indication for doing? Sialoadenectomy?
Sir, there are two indications. One is if there is actual pathology in the submandibular gland.
No. In the background of stone.
In the background of stone.
In the background of stone, when you do like to consider doing a submandibular sialoadenectomy?
So like in this case, where there is chronic sialoadenitis due to stone, and then it is one indication, or if the stone is very proximal to the gland,
If the stone may form in the gland itself. It's an intraglandular stone, you need to do submandibular. If it's a site of chronic infection, the swelling is now disappearing in between meals. In that case, if you remove the stone, patient will have seat of this infant gland. So that is the indication. If the swelling is persistent and then there is evidence of sialoadenitis, the swelling is not getting disappeared in between meals, you should consider doing a sialoadenectomy. Okay. So describe the steps of submandibular sialoadenectomy. Before that, you just tell me what are the vessels in relation to the submandibular gland?
The vessels means artery and veins, or no.
Vessels. How can now
artery and vein? The artery and vein is the first we see the anterior facial vein. It might come in the way. Then the facial artery and the facial vein.
Where is it? If you take the gland has a superficial part, superficial the mylohyoid, and deep part in between mylohyoid, fibrosis. Where the facial artery comes in relation. You said one statement you made, I was not liking that comment. On inspection, you say the upper border of the gland can be seen. You can hardly see the upper border. You see, if you take the gland has got an anterior border, posterior border, lower border, upper border. Upper border is going deep to the ramus of mandible. Okay, body of mandible, it is easily not seen. Upper border of the gland easily not seen. Okay, so if you take this now, the vessel muscular relation, Where does the facial artery comes in relation to the gland?
Sir, once the
Facial artery is a branch of?
no, sir, not so, sir.
You must be knowing the branches of external cardiac artery. Facial is a branch of external cardiac artery. What is the first branch of external cardiac artery? क्या भाई? First branch of external cardiac artery. ये तो पता ना ये. हाँ? क्या भाई? Ascending pharyngeal artery. Next is very big branch. Ascending pharyngeal. Next is what comes to the thyroid? Suprathyroid. Suprathyroid. Then facial. Then comes what? Continuation. Continuation artery. Terminate as. And how does it terminate? How does the external cardiac terminate? Indrani, how does the external cardiac artery terminates? External artery goes up, goes by the ramus of mandible, and terminates by dividing into. अरे भाई दो ब्रांच है, तो बोल रहा था. Last time I was wrongly saying something called maxillary artery. It terminates by dividing into social, temporal, and maxillary artery. External cardiac artery branch पता नहीं. What are the branches of internal artery in the neck? Branches of internal artery in the neck? No branch. That is how I identify. That is how you identify the external and internal artery in the neck. Where does the common cardiac artery ends? What is the landmark? Where does the common cardiac artery terminate? C6 तो पीछे है. सामने कैसे पता चलेगा? C6 पीछे है. हाँ? हाँ? Cricoid है, इसे common cardiac है. Cricoid level पे. C6 जो है, in the level of cricoid, that is a common cardiac artery. As you trace it up, it bifurcates. Where? At the level of upper order thyroid cartilage. Okay, that is the point where the cardiac bifurcates. And the other branches of external cardiac. In the neck, internal cardiac has no branch. Okay, fine. And then you got the facial artery and vein at the lower border in the posterior part of the gland, posterior pole of the gland. Any other place where the facial artery comes in this?
Yes, sir. Once we retract it fully again, we will see
Where?
the facial artery. Sir, so initially
in the lower pole, it goes around the gland. And what happens to the artery in the upper pole?
sir, it is present behind the gland in the upper pole.
And where it goes?
It goes.
Goes to the face. If you talk of this area, the artery goes around the lower pole of the gland and then runs on the surface of the gland. At the upper pole, it turns around the mandible to go to the face. That is the course of facial artery. So facial artery and vein will come twice while you are doing submandibular sialoadenectomy. What nerves come in relation to the submandibular gland?
The lingual and the hypoglossal.
Best. Start with the slow to deep.
Marginal mandibular.
Yes.
Marginal mandibular.
Marginal mandibular. Branch of?
Facial nerve.
Okay. And another nerve comes close to this.
Marginal mandibular, lingual and hypoglossal. And
cervical branch of facial. Cervical branch of facial.
cervical branch.
Supplies what? Cervical branch in the neck में आ रहा है. How can the supply branch? Platis. Yes. So this nerve, this mandibular and the cervical branch of facial, how do you protect while these sialoadenectomy? How to protect this nerve if you are not cautious while doing sialoadenectomy? This nerve may be injured. What are the points for preserving those nerves?
So ideal method is while raising the skin flaps itself, we should raise along with the deep fascia.
When you made the incision?
We make the incision 2 centimeter.
At least 3 centimeter.
3 centimeter below the.
This is the lower border of mandible. These nerves lie along the lower border mandible and then turns upward to supply what? Marginal mandible supplies what?
Orbicular oris.
Yes,
muscle.
and the lip muscles.
Lip muscles.
It supplies the orbicular oris and the lip muscles. So this nerve has to be preserved by making the incision at least 3 cm below the lower mandible. And while you want to raise the upper skin flap, you have to deepen the incision skin, saphenous tissue, platysma, and the invisible discoid. So this upper skin flap has to be raised in composite of these layers. So if you start lifting, the nerve will be in between the
deep fascia and deep platysma.
Yes. So that is how you protect the
marginal mandible.
So the two nerves comes in relation superficial, marginal mandibular and superficial. Two nerves come deeper. One is lingual and another is hypoglossal. Okay. What is the relation of lingual nerve with the submandibular gland?
Sir,
relation of lingual nerve submandibular gland. If you trace the lingual nerve, as it comes down, how does it supply the submandibular gland?
Sir, it actually starts from the superior pole and crosses the first it is superior to the submandibular.
Is there a ganglia into the lingual nerve?
Yes, sir. Submandibular ganglion is
Yes.
present.
So as you trace the lingual nerve, as it comes to the upper pole of the gland, it goes along the upper pole of the gland, and there is a ganglion there. And then the lingual nerve takes a course, which goes around first superior and then inferior
around,
and hooks around the lingual nerve.
It's a submandibular duct.
Submandibular duct. Okay. How does the secretory motor fiber reaches the submandibular gland? What is the origin of this secretory fibers and what route they reach the submandibular gland?
So the through the first is the secretomotor fibers, then the
there are two salivary nucleus.
Superior cervical
yes.
nucleus.
For submandibular, superior. For parotid,
inferior salivary.
So this secretory fiber starts in the superior salivary nucleus, and as it goes with which nerve?
Sir, the chorda tympani, the facial nerve, and then the chorda.
First is facial. Okay. First is facial, and then one branch of facial is chorda tympani. And from chorda tympani, it reaches the lingual nerve. What happens to this in the ganglion? These are parasympathetic fibers. It has got a preganglionic fiber and a postganglionic fiber. This fiber up to the chorda tympani is what? Pre or postganglionic? Postganglionic. What is the ganglion?
Sir, submandibular gland. So preganglionic.
Preganglionic fiber. From superior salivary nucleus, we have preganglionic fibers going along the chorda tympani, facial, and then to the lingual nerve. And from the lingual nerve, it gives branches to submandibular ganglion. Postganglionic fibers arises and then supply the salivary gland and the submandibular gland. Okay. Where does the hypoglossal nerve lies?
Sir, it lies in the floor of the hyoglossus muscle.
So this hypoglossal nerve lies deep to the deep part of the gland. Lies deep to the deep part of the gland. The lingual nerve lies in the upper pole. Hypoglossal nerve lies in the front of the mouth, deep to the deep part of the gland, on the hypoglossal muscle. What will happen if you injure the hypoglossal nerve?
Sir, there will be.
What will happen?
Sir, ipsilateral deviation of the tongue will be there.
Huh?
Sir, like on the affected side, the tongue will be deviated. Ipsilateral deviation.
So there will be
paralysis of the palatal.
There will be paralysis of the ipsilateral side of the tongue. That you project, it goes to the disease side because of the other muscle pushes it to the opposite side. Okay. So the other nerves. So describe the steps of submandibular sialoadenectomy. You are doing a right-sided submandibular sialoadenectomy. Describe the steps.
Sir, so the patient is in supine position with the neck slightly extended to prevent venous congestion. Anesthesia is.
Whatever term you are using should be perfect. You say neck extended to reduce venous congestion. Does it?
15 next.
Extension of neck doesn't cause reduction of venous congestion. Extension neck is required to open up the space. You need mild extension of the neck by putting a sandbag in the shoulder blade and then head and elevate by 15 degrees. That reduces venous congestion. Then what?
So then the chin is directed towards the opposite side of the surgery.
Yes.
Sir, then anesthesia, general anesthesia with endotracheal intubation can be done. And sir,
When you talk of position of the patient, do the position first and then give anesthesia?
no, sir, first we give anesthesia and
Anesthesia first, then position of patient. Because once you patient is supine, doesn't matter at what position you want to what. But once the patient needs a special position, in that case, anesthesia is first, and then go for
Then
the
go.
position.
General anesthesia with endotracheal intubation, then position of the patient, that is neck is extended, sandbag is kept between the neck and the shoulder, and 15-degree extension, along with the chin is directed to the opposite side of the surgery. And so the patient is draped with the 3-towel technique. And after antiseptic dressing and draping, we proceed on with the surgery. Incision is placed 3 centimeters below the angle of the mandible. Once the incision is placed,
Angle of mandible is here. He's not below the, you see, the line is this
Line
lower
is-
border. See, below the lower border of the mandible. And medial extent, lateral extent.
sir, medial extent is 2 centimeters just lateral to the midline.
Right. And
Sir, and lateral extent is still the angle of the mandible. Sir, then the 2 skin flabs are raised, the upper skin flab and the lower skin flab.
then I told you.
And the thickness of the skin flab is
So
very important.
once you make the skin incision, deepen the incision to the platysma, superficial fascia, and the deep fascia, and raise the upper skin flap
with all the
with this 3 layers. Okay. Then
So, sir, then we will face the anterior facial vein, which needs to be ligated. Sir, and then what we'll do is we'll hold the superficial part of the submandibular gland. We will retract it superiorly. So once we retract it superiorly, we can see the facial artery and the vein. The first time we are seeing the facial artery and the vein.
like we say, I prefer to describe the these steps with some headings. The first ring of the incision. Second is raising the skin flap. Now third heading will be ligation of anterior facial vein. Fourth will be tackling the facial artery and vein and the lower part of the gland. That is the heading. And under this, you dissect the lower border of the
Gland
gland
and then retract it.
and then direct superiorly, facial artery and vein comes in. Dissect, ligate, and divide. Yeah. Next.
Sir, then we will retract it a little more so that we will see the facial artery and the vein the second time in the surgery.
So once you have done the lower pole, now it's the time to go to the upper pole, the superficial part. So try to dissect it from the mylohyoid. It is resting on the mylohyoid. Dissect this upper pole. And as you do the upper pole dissection, again the facial artery and vein will come. So it is again dissected like in the upper pole. Once this is done, next you try to go in between what?
Sir, in between the mylohyoid and the hyoglossus.
Yes.
So what
There
we do
lies the
is
deep part of the gland.
we retract the mylohyoid.
Once you go deep part of the gland, what you do next?
Sir, we will try to slowly dissect the submandibular deeper part of the gland. So this is where we face the lingual nerve. So we should
Yes.
take utmost care to not damage the lingual nerve and dissect it from the.
Okay.
So once we do that, then we'll have to dissect the deeper part of the gland from the floor of the mouth.
How do you separate the lingual nerve from the gland? As the lingual nerve goes down, it gives up branches to submandibular ganglia. Got my point? You have to divide the branches of the lingual nerve to submandibular ganglia.
That's fine, sir.
And then see that the lingual nerve is going around the duct. So once you dissect the upper pole of the deep part, you separate from the lingual nerve, dividing the branches to submandibular ganglia. And then while lifting the gland in the hyoglossus, you find what?
Hypoglossal nerve will be there.
That should be preserved. And then you dissect the duct towards the throat of the mouth. If you are finding the stone, if you dissect the duct, the stone in the duct can come out. You may ligate or you may not ligate the duct. Okay, if you go beyond the stone, you can ligate the duct there. Okay, so the gland is removed. Closer.
Sir, we will first keep a room of suction drain in place, and then so the platysma can be closed with 3-0 vehicle or 2-0 vehicle. Sir, then the skin can be closed with either subcuticular or
Host of complications.
Sir, bleeding, hemorrhage, and sir, like specific complicated damage to the lingual nerve, damage to the hypoglossal nerve can have its complication. Damage to the lingual nerve. Actually, lingual nerve supplies the anterior part of the tongue. It carries the general sensation as well as the
Taste sensation.
taste sensation. Taste sensation is through the facial nerve, and the general sensation is through the glossopharyngeal nerve. So, so when lingual nerve is damaged, the anterior sensation to the anterior part of the tongue is
We should
lost.
not supply the posterior part of the tongue for test.
For
Lingual nerve supply anterior to that. We should not supply posterior one that.
the chorda tympani, glossopharyngeal nose.
Glossopharyngeal. Also the posterior one that. Okay. In this short case, nothing much to discuss. So, any question from the audience? Any question from anyone? You see, for the short case, it did not go to the such depth of history. In exam, in the short case, you'll be, but in DNB, there is nothing called short case. In MS exam, we'll have short case. So give just a brief summary of the patient. You need not go into the personal history, family history, everything. But in DNB exam, if you are given 2 or 3 cases, I don't know what will happen the next time. At the moment, they are giving 2 cases. But the pattern for DNB was giving the student 4 cases. But with introduction of OSCE, the number of cases has gone down. But whatever, if you given 2 cases, you consider 2 as a long case. So whatever case is given, you approach it as a long case, taking the details history and then giving the details of the patient. Okay. So any question? Must read the anatomy properly. Anatomy of salivary glands, anatomy of the neck vessels. Okay, so these are all important. Anything, really, this is a short case. So examiner can ask me anything. If you are asking about the external credit, you can answer that. It's a discredit. That goes against your case presentation. Okay. Then you close today. Okay.
Thank you, sir.
Thank you.